Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we're going to discuss about the treatment of endometrial hyperplasia. So in the previous module, we have discussed about certain important procedures now. So we will conclude everything with the treatment of endometrial hyperplasia. So we dealt with in the previous module that endometrial hyperplasia is nothing but the proliferation of the endometrial glands, which is going to be more than in the ratio of 1:3, more than 1:3, right? Yes, and this endometrial hyperplasia can be with atypical nuclear features or without the atypical nuclear features. So we are going to classify this endometrial hyperplasia into either endometrial hyperplasia with atypia or endometrial hyperplasia without atypia. So we'll be discussing about the treatment in two sections. The first section we are going to discuss about the treatment of endometrial hyperplasia without atypia. Okay. So now what is endometrial hyperplasia without atypia? So as we all discussed earlier, without atypia means without atypical nuclear features. There are no atypical nuclear features or there is no atypical cells being present. Is that clear? Yes. So endometrial hyperplasia without atypia is where the atypical nuclear features or atypical cells are not present. So it is just the proliferation of the uterine glands. Okay. So now what is the chances to progression of malignancy from this condition? So endometrial hyperplasia without atypia has very less chances for progression to malignancy, and the chance is like nearly it is 1 to 8%, which is roughly less than 10%. Okay, so the chances of progression to malignancy is less than 10%. Okay, so now what is the treatment? So what are the treatments you're going to consider in this patient? So basically, a patient came to you with complaints of abnormal uterine bleeding. So you did all the preliminary investigations and then you did the endometrial biopsy. In the endometrial biopsy, the report came to be as endometrial hyperplasia without atypia. So you know that without atypia means the chances of progression to malignancy is less than 10%. So now, how are you going to manage her? So the primary goal is to control the bleeding in that female, right? She's going to come to you with complaints of abnormal uterine bleeding. So as a doctor, as a gynecologist, your responsibility is to control the bleeding. And how are you going to do that? So the drug of choice for the treatment of endometrial hyperplasia without atypia is progesterone. So as we all know, progesterone has the function of anti-proliferative effect, right? Estrogen has a proliferative effect and progesterone has an anti-proliferative effect. So because of that reason, this progesterone is going to support the uterine endometrium, and since it is going to support the uterine endometrium, it is going to result in thinning or atrophy of the endometrium. So because the endometrium is going to be very thin, therefore the bleeding will get regressed. So the patient will never have complaints of abnormal uterine bleeding. The bleeding will get controlled. Okay, so now this progesterone, which is going to give support to the uterus, can be administered by two ways. Either it can be administered orally or it can be given by intrauterine contraceptive device, that is the Mirena. Can you recall it? Yes, we have discussed in the previous module that the Mirena is also known as LNG20, right? Because it releases about 20 micrograms of levonorgestrel, that is the progesterone, per day. And what is the total amount of progesterone present in IUCD Mirena? It is about 52 milligrams. Yes, good. Okay, so now this progesterone can be administered by either orally or by intrauterine contraceptive device. If you ask me which is the preferred option among these two, the most preferred option is the IUCD Mirena, right? Okay, so this symbol, it is telling that it is more preferred. Okay, so the preferred one is IUCD Mirena, but in case we are going to adopt an oral option, what are the options which are available to you? So either you can give the oral progesterone for a continuous period of time, or you can give it cyclical. Let's say, for example, you're going to give that for a period of about 2 weeks and then ask the patient to stop it. Then she has to continue it for the next menstrual cycle. So for every cycle, she has to take it for around 14 days and she has to stop the tablets. She's going to have withdrawal bleeding, and then for the next cycle, next menstrual cycle, she has to start taking the tablets for another 2 weeks and she has to stop it. So subsequently her cycle will also get regularized and the bleeding will also get settled. So either you can give by continuous route or you can use the cyclical for around 2 weeks, right? So you give for 2 weeks, you stop, withdrawal bleeding will happen, and then once the bleeding is going to stop, in the next cycle you have to ask the female to continue it for the next 2 weeks, right? Okay. So the oral options which are available to us are 2 tablets, right? So one is going to be megestrol and the other is medroxyprogesterone acetate. Both are given by oral route, right? So megestrol, which is the progesterone, which is given in a dosage of 40 milligram, it is given twice a day, right? And medroxyprogesterone acetate, it can be given somewhere around 10 mg to 20 mg, and it is also prescribed in twice a day manner. So the oral options which are available are the megestrol and medroxyprogesterone acetate, which are the progesterones, and you're going to give this progesterone either in a continuous fashion, or you ask the female to take it cyclical for around 2 weeks and then ask to stop and then continue it for the next menstrual cycle for around 2 weeks. Yes, good. So this is all about the management of endometrial hyperplasia without ATPia. Now you may have the doubt that why are you not going to do any definitive management in that patient? Why are you just planning to stop everything? Why are you planning to support the endometrium and decrease the bleeding in that female? Because as we all know, the chances of progression to endometrial hyperplasia without ATPia to the further stages is actually, that is, the progression to malignancy is actually less than 10%. So because of that reason, the only treatment of choice which you need to do is to control the bleeding. So that can be facilitated with the administration of progesterone, which has the anti-proliferative effect on the endometrium. Yes, okay. So now you have given progesterone either by Mirena, that is the IUCD, or you have given orally. So now her bleeding is getting controlled. She is not having any abnormal uterine bleeding. The bleeding is getting controlled in her. So now, are you going to just leave the patient? Are you going to have the patient in a follow-up? You have to ask the patient to be in the follow-up for around next 1 year. So for the next 1 year, you have to advise the patient that you need to be in follow-up with me. How she should be in follow-up with you? So for the next 1 year, you have to repeat the endometrial biopsy after 3 months. Right, 3 to 6 months once you have to repeat the endometrial biopsy. So endometrial sampling has to be repeated every 3 months once for the next 1 year, 3 to 6 months once for the next 1 year. So roughly it will be done around 2 to 3 times in the next 1 year. So if you're going to do this, repeat this endometrial sampling for the next 3 times in the next 1 year, you have to see the reports. So the reports could be either same the endometrial hyperplasia without ATPia is just persisting, or it has progressed to endometrial hyperplasia with ATPia. So either you check whether the same condition, that is endometrial hyperplasia without ATPia, is persisting still, or it has progressed to endometrial hyperplasia with ATPia. So if it has not progressed, right, let me just correct it. If it has not progressed and endometrial hyperplasia without ATPia is just persisting, what are you going to do? So without ATPia still persisting, now you have to arouse suspicion that there could be chances of progression yet. So you need to do some definitive procedures. Why? Because is that the condition of endometrial hyperplasia without ATPia is still persisting in the female despite the management. So you have done the medical management. So despite doing the medical management, and you are going to repeat the endometrial sampling every 3 months for the next 1 year, and for the next 1 year when you repeat the endometrial sampling, the endometrial hyperplasia without ATPia is still persisting, or you can tell that the patient is still continuing to bleed. So despite the medical management, the patient is continuously bleeding, and the patient is also having the same endometrial hyperplasia without ATPia still persisting. So in that cases, you have to do the definitive investigations. And so the definitive investigation to assess the endometrium is always, please remember, it is the fractional curettage and hysteroscopy. Why are you going to do fractional curettage and hysteroscopy? Because despite the medical management, the patient is still continuing to bleed. That is one indication. The other indication is that despite the medical management, even after 1 year, the endometrial hyperplasia without ATPia is still persisting. So in that case, you have to definitely assess the endometrium. So the gold standard investigation to assess the endometrium is fractional curettage and hysteroscopy. Right? Okay. But if it has progressed to endometrial hyperplasia with ATPia, how are you going to manage? So we have discussed about endometrial hyperplasia without ATPia. So now we are moving into endometrial hyperplasia with ATPia. So endometrial hyperplasia with atypia, what are you going to do? What is endometrial hyperplasia with atypia? That is proliferation of the uterine glands in the ratio of more than 1:3, and in this case, the atypical nuclear features or atypical cells are present. So you can take it as atypical nuclear features are present. So since the atypical nuclear features are present, therefore the chances of progression to malignancy is much more when compared to the endometrial hyperplasia without atypia. How much is the probability? It is around 40% risk is there for the chances of progression to malignancy. So in this patient, definitely you need to rule out the endometrial cancer. So how are you going to rule out the endometrial cancer? Because the progression to malignancy is much more, that is 40%. So rule out the endometrial cancer by assessing the uterine endometrium. And the gold standard investigation to assess the uterine endometrium is fractional curettage and hysteroscopy. So you do the fractional curettage and hysteroscopy, check whether the endometrial cancer is present. If the reports of fractional curettage and hysteroscopy comes out to be no endometrial cancer, what are you going to do? So now what you're supposed to do is that since the chances of progression to malignancy is 40%, now you definitely know the management in this patient. You can't leave the patient, or you can't ask the patient to just be in the follow-up, because you can ask a patient who is having endometrial hyperplasia without atypia to come in follow-up with the medical management. But you cannot ask any patient with report of endometrial hyperplasia with atypia to be in follow-up without doing any definite management. So since the chances of progression to malignancy is 40%, you have to do some definite management in that patient. So you ask the patient, you counsel the patient, explain to them the risk of progression to malignancy. So you just check the patient age, whether she is belonging to premenopausal age group or perimenopausal, the period of 4 to 5 years before the attainment of menopause, that is around 47 to 51 years in the Indian population. Right? So before 47, 3 to 4 years before 47 to 51 years. So that is the perimenopausal age group. So in all pre and perimenopausal age group female, you have to do total abdominal hysterectomy. You remove the uterus and the cervix. Right? And in all postmenopausal female, that is any female who has attained the menopause between 47 to 51 year, any female who has attained the menopause, she is a postmenopausal female. So in postmenopausal female, you can do total abdominal hysterectomy with bilateral salpingo-oophorectomy. What do you mean by total abdominal hysterectomy? So abdominally, you are going to remove the uterus. That is called as total abdominal hysterectomy. Hysterectomy is the process of removal of the uterus with the cervix. Right? So total abdominal hysterectomy is done. What is bilateral salpingo-oophorectomy? Bilateral is both. Salpingo is fallopian tube. Oophorectomy is the ovaries. So total abdominal hysterectomy means uterus with the cervix. Bilateral salpingo-oophorectomy means both the fallopian tubes and both the ovaries are removed in case of postmenopausal female. Now you may have the doubt that why pre and perimenopausal age group female you are going to do only the total abdominal hysterectomy and not bilateral salpingo-oophorectomy, but why in postmenopausal female you are going to do total abdominal hysterectomy and bilateral salpingo-oophorectomy? It is because of the fact that we all know that from the ovaries we have the hormone estrogen, right? So estrogen is the most important hormone in any female, because estrogen is the hormone which is going to protect the female from many other adverse effects during her reproductive age group life. Until the attainment of menopause, the female is actually protected from hypercholesterolemia and then coronary artery diseases and osteoporosis, atherosclerosis and much more. So all these risks are actually avoided in a female who is menstruating, because in a menstruating female, definitely estrogen is going to be active because ovary produce the estrogen. And in all females, the ovaries are active until the menopause. So until the menopause, the ovaries are active and therefore estrogen is going to be produced from the ovaries, and this estrogen is very important to protect the female from many adverse effects. So since in peri and premenopausal age group female, estrogen is very important, so you're going to leave the ovaries and remove only the uterus and the cervix. So for the beneficial effect of the female, you're going to leave the ovaries because ovaries produce the estrogen. Estrogen is important to prevent the female from many other risks and adverse effects. So leave the ovary, remove the uterus and the cervix in pre and perimenopausal age group female. But in postmenopausal female, definitely estrogen is not produced by the ovary. So you remove the uterus, cervix and both the fallopian tubes and both the ovaries. Is that clear? Yes. So this is the management of endometrial hyperplasia with atypia. Okay. So now I have an interesting case for you with which we are going to conclude this topic of endometrial hyperplasia. So let's get inside the topic case now. So the case one is that a 45-year-old female. She's complaining of abnormal uterine bleeding. I'm not giving any other history for you now. So just the history which is given to you is a 45-year-old female complaining of abnormal uterine bleeding. So you can take it as a perimenopausal age group female. Why perimenopausal? Because the period of 3 to 4 years before the attainment of menopause is the perimenopause age group. So a perimenopausal age group female complains of abnormal uterine bleeding. And as per the protocols, we know that in all reproductive as well as in the perimenopausal age group female, you have to do UPT in order to rule out implantation bleeding. In order to rule out pregnancy, you do the urine pregnancy test. If the urine pregnancy test comes out to be negative, you have to do the ultrasound. And in ultrasound, there could be anything in the ultrasound. Let's say, for example, a fibroid is present or something is present, a polyp is present, adenomyosis, anything is present. Irrespective of the ultrasound report, you have to do endometrial biopsy in that patient as per the protocol. Because the protocol tells us that any female who is more than 40 to 45 years of old with complaints of abnormal uterine bleeding, irrespective of the ultrasound report, you have to do the endometrial biopsy. So as per the protocol, you do the endometrial biopsy and the endometrial biopsy comes out to be endometrial hyperplasia with atypia. With atypia means the chances of progression to malignancy is around 40%. So since the chances of progression to malignancy is more, you have to rule out the endometrial cancer being present in that female itself. So in order to rule out the endometrial cancer being present in that female, you do the fractional curettage and hysteroscopy, where you're going to just subject every sections of the uterus to histopathological examination, and the reports of fractional curettage and hysteroscopy comes out that there is no endometrial cancer. But then still there are chances of progression is still more. You advise and counsel the patient for hysterectomy. What hysterectomy you're going to do in perimenopausal age group female? You do only the total abdominal hysterectomy. You remove the uterus with the cervix. Yes. So if the patient is going to agree for hysterectomy, you do the hysterectomy in that patient. But in case if the patient is going to refuse, what are you going to do? If the patient is going to refuse, are you going to force the patient and remove the uterus? No, we cannot do that. As a doctor, as a clinician, it is our duty to inform the patient about whatever condition has been present in her and the risk factor for the progression to malignancy. But we don't have any rights to do anything apart from the patient's knowledge, right? So that is what consent tells us, right? So the medical laws rules with that same. So if the patient is going to refuse, you can provide the patient with an option that you tell her, okay, fine. So now you are actually refusing for hysterectomy. You don't want to do hysterectomy now. Okay, now I will start you with some other management. So let's watch out whether it is getting regressing or not. If there is progression now, then you have to agree for a hysterectomy. That is first. If the patient is going to refuse, you do some other management, and the management is progesterone. Progesterone is anti-proliferative in nature. It supports the endometrium. It settles the uterine bleeding. It is going to correct the uterine bleeding, right? So you start the progesterone either orally or by IUCD Mirena. And you also keep the patient in follow-up for the next 1 year. For the next 1 year, keep the patient in follow-up. So for the next 1 year, every 3 months or every 6 months once, you're going to repeat the endometrial biopsy. If the endometrial biopsy comes out to be the same endometrial hyperplasia with atypia still persisting, or the patient is still continuing to bleed, in that case, it is high time you have to take some action. If you're not going to do anything, there are increased chances of progression to malignancy. So now you have to advise the patient that you already refused to do hysterectomy, so that I started you with some other alternative mode of treatment. So now still the endometrial hyperplasia with atypia is still persisting, and if you're not going to adopt hysterectomy now, there are increased chances that you might land up in endometrial cancer as well. So now if the patient is going to agree, you have to do hysterectomy in that patient. And what is that hysterectomy? It depends upon the age group, whether she is a peri or a premenopausal or a postmenopausal. If she is a postmenopausal, do total abdominal hysterectomy with bilateral salpingo-oophorectomy. If she is a perimenopausal age group female, do total abdominal hysterectomy and leave the ovaries and fallopian tube. Is that clear? Yes. So this was all about the endometrial hyperplasia with atypia and without atypia treatment. So I hope I made everything clear for you. So because of that reason only, in the previous module I taught you about fractional curettage and hysteroscopy. So now you may have a rough idea about what is actually endometrial hyperplasia and what are the chances of progression and how it is being treated, what is the action of progesterone, what is IUCD marina and such. So in the subsequent module you'll be dealing with even more deeper before we arrive at the climax of this topic, that is endometrial cancer. Right? So I hope everything is very clear and I made much simpler for you. If you have any doubt, please write us to the Mackler Instagram or the Gmail handle. We will reach out to you as early as being possible. And please subscribe to this Mackler YouTube handle and Instagram handle so that you will get the daily video updates. And if you have any feedbacks, please write to us. It will be much more encouraging for us. Thank you.